Yeah, so at least Dr. Madisuri had just one complication. I managed to create three in one case. So, yeah, I titled it Tore, Leaked, and Lost. So we'll find out what it is. Yeah, so 72-year-old male. He's an ex-smoker, multiple DVTs, Ps. He's on anticoagulation. He had a filter placed 12, 14 years ago, COPD, and he was seen in previous hospitals. He underwent some IVC and iliac venoplasty, and he continued to have non-healing venous ulcers. Previously, they tried to take the filter out. It was not successful. I did an arterial evaluation. It looked pretty good. Ultrasound showed typical continuous flow in the common femoral veins, very, very suggestive of upstream obstruction or compression. So this was his lower extremities, very consistent with finding of venous. So this is the CT. It plays real quickly. I think the rest of it, for some reason, I was not able to download it, but that's the Optis filter. So in my practice, when I first started, we used to send all our patients to Mayo or to Denver to get the filters removed. We didn't have laser, but our patients really hated that, because they had to go all the way to Denver and then take time off, and it was just not feasible. And in Rapid City to Denver to Mayo is like literally 9 hours of drive, and these patients live paycheck to paycheck. So therefore, I started this filter removal using laser technology. Can you guys go forward? Yeah. And I've done a fair number of these, so I felt confident. These were the venograms. So this is my strategy. So this was an opti, so I decided to take it out from the groin. So I have a Gore 16 French sheath, and then I have the laser sheath, which is 16. Then I have this endoscopy forceps, and then I have another wire next to it. I just use a balloon to dislodge the filter, or if I need to place any kind of stenting. So did that, and I tried hard. I was performing laser for quite some time, and if you notice, the dimension of the upper circumference or the upper portion of the IVC filter had not changed at all completely. So I thought maybe grabbing with the forceps was not a right idea. So I tried to lasso it and do it that way, and see if I could change the forces. Next slide. And didn't seem to work. So can you go back a slide, please? Yeah. So I decided to just watch him and talk to the patient and the family member who actually works in the hospital, and said, like, should we manage this medically, and should we refer you to a different center? And they were like, no, I want you to try again. So I brought him back again after a few weeks, took some more pictures, and I said this time, knowing what happened last time, given that the upper portion of the IVC filter was not able to shrink, I said maybe I should come from IJ, and that's what I did. And so I came from the IJ, did that, typically put a Omni, and then put a soft angle light wire and kind of snare it, and then did the same thing with the Gore sheath, and then I have the laser. So I was kind of getting down there. I felt like quite confident. And next slide. And finally, I was able to pull out. But unfortunately, as you can see what's happening on the right side of the screen, I just pulled out a piece or two, but a good chunk of it was still stuck in the wall, and there's some bits and pieces hanging up there. The patient's totally stable, and I usually do this with anesthesia. So the anesthesiologist said everything's pretty good, nothing to worry. Next slide. And this is what we pulled out. Okay. So what I do is I usually place my catheter in a position. I use a finder catheter, kind of line that up with different audio angles, and then I bring in my, the forceps, and I manage to pull out some pieces, and this is what I got out. So, and this is what happened next. So that's complication number one. So what you see is a tear, and for people who do transcaval, TAVRs or impellers, something to remember that the pressure, the interstitial pressure in the retroperitoneum is higher than the IVC pressure. So often you seldom see blood leaking out from the IVC, and they seldom become very, very unstable. But when you see some decent amount of leak happening, so that tells you it's a fair amount of tear. So anyway, uh, what did we do? I put in 2 Gore endographs. So put in a 26, caudally, and then cranially I put a 28 by 33. I do IVUS to assess the size, and this was the IVUS just after stenting to make sure I landed proximally well and distally well, which I was happy. And then went ahead and assessed the rest of the IVC on both the sides. There was some chronic disease here, and previously had already undergone some venoplasty, no luck. So with the continuous flow, I decided to put kissing artery stents into the IVC. And then I just finished off with an IVUS. And then in the interest of time, I'll get you to the next slide. So he was up on the floor, step down unit, and 4 hours later, I got a call. He's extubated, recovering. Oh, he's got abdominal pain. I said, oh, did I miss something else? Or did any of this, leftover IVC filter pieces migrate somewhere? So he's hypotensive. He did the usual stuff, got him to CTA. They said, yeah, he's got an RP bleed, but they don't see any active extravasation. So he comes back from the CT scanner. He starts to get really sick. He's hypotensive, respiratory failure, gets tubed, and mechanical ventilation. So what are you guys thinking right now? What would you guys do? Call the vascular surgeon? For what? What's the problem? Hemoglobin came back stable, totally stable. At this point, he's already tubed in this thing. So I looked at the monitor. And in the monitor, he's got the typical electrical and pulses alternance. So what this guy had was a tamponade. So that's number 2. So what I suspect happened was, to Dr. Madhusevri's point, that, don't change what you do and what you used to, because we are so dependent on tactile and visual feedback. So usually I place a Amplatz wire to, deploy my stents. And usually it's a 7 centimeter soft tip, and I know where the distal end of the wire is sitting. So I put a 1 centimeter soft tip. And with all that happening, I suspect that's the most likely cause. So anyway, we took care of this, tapped it, and looked good. And patient was pretty stable, recovered really well on the table. And next slide, please. Yeah, and this was the pericardial drain. So you guys see something else? Yeah, so there's a piece there. So obviously, is this is that the IVC filter? It's probably more plastic. So it was a fractured foreign body. It's probably one of the diagnostic catheters, and I didn't check. So maybe while trying to snare and remove this, I must have fractured it. I took different views and thought I could snare it out. Next slide, please. And actually, it was buried pretty deep. And so I talked to my CT surgeon and pulmonology team, and my CT surgeon was actually not impressed. I said, oh, every now and then this happens to us. I would just leave it alone, put them on antibiotics, keep a close eye. So he did remain in the hospital for the 6 to 7 days. Next slide, yeah. And I just checked the flow up here to make sure we didn't miss anything else. So that was all well sealed. And he did develop a decent amount of bronchitis and post-obstructive consolidation on the left side. But, got extubated. Next slide. After 3 days. After 3 days, and then subsequently after that, he recovered and he went home. And he had a follow-up ultrasound CT in about 6 weeks, and everything was doing well. His ulcer healed. It took a little while, but definitely healed. So the moral of the story for me was, I guess, don't change the techniques. One, number 2, I think IVC filter retrievals, chronic ones, are very, very, very challenging. Yeah, so good. Questions and critiques and what I can learn from? Thank you.
know, having taken out a lot of these crap teases, most all of them I do at the same time. You have to sheath both top and bottom at the same time, and sometimes flip your laser top to bottom and keep, because that inevitably what happens is that it separates. They're just a horrible filter, and thankfully they're done. But I think dual access every time for those are the only way to get those chronic ones safely out. But great recovery in the end.
The only thing I want to add, since I think we still have fellows here, right, is that when I was in training, my chairman used to say, "You look for what you know, you see what you look for." So it's not so much in this setting, but more in cases of SVC work and things like that. If they're crapping, we're pericardial.
Very good.
I've had